Good afternoon, everyone, and thank you for your attention and the opportunity to present. My name is Lieutenant Commander Michelle Ganyo, and I'll be discussing our initiatives of implementing a program to improve screening colonoscopies at Naval Medical Center, San Diego. I have no disclosures. The performance quality of screening colonoscopies can vary amongst endoscopists and be a challenging objective to measure. In 2015, the American Society of Gastrointestinal Endoscopy and American College of Gastroenterology Task Force on Quality in Endoscopy released updated guidelines on measuring quality in colonoscopy. Included were a number of recommended metrics with benchmark goals that serve as measures for endoscopist performance. The benchmarks for average screening colonoscopies include a frequency of adequately bowel preps greater than 85%, cecal intubation rates greater than 95%, withdrawal times greater than 6%, and overall adenoma detection rates greater than 25%, which can be broken down to greater than 30% for males and greater than 20% for females. Colonoscopy remains the gold standard of colorectal cancer screening as it has the ability to detect and remove precancerous lesions. Of the quality metrics mentioned, adenoma detection rate is by far the most important due to its association with a decrease in interval cancer rates. Adenoma detection rate is defined as the number of average-risk colonoscopy exams with adenomas divided by the number of average-risk colonoscopy exams performed. Studies have demonstrated that with every 1% increase in an individual endoscopist's ADR, there's an associated 3% decrease in interval colon cancer. Thus far, this relationship has not plateaued, thus every surgeon has the opportunity to improve their ADR. One proven method to improve ADR is by simply educating endoscopists on their ADR and the different endoscopic techniques to improve their screening colonoscopies. A follow-up study to the one previously mentioned demonstrated that education had a sustained improvement in ADR after a 3-month period. At NMCSD, we have a combined endoscopy unit composed of both gastroenterologists and surgeons. In this quality initiative, we aim to implement a process that tracks the quality metrics with regards to the benchmarks mentioned for average risk screening colonoscopies, establish our baseline performance as a combined unit, and then within each department with regards to these metrics, provide education to our staff on the techniques to improve ADR, and finally perform a short-term data analysis to assess the response to education. Our baseline data was determined by a retrospective review of all average risk screening colonoscopies performed at our institution from January 2016 to April 2017. We then presented this data and education on how to improve ADR to all of our endoscopists. A 6-month review was then performed after the education to assess our endoscopist performance. Our main area of interest was the progress of ADR after staff education. However, we also collected data on the adequacy of bowel preparation rates, cecal intubation rates, and withdrawal times. So as a combined endoscopy unit, we were performing quality colonoscopies and were above the national benchmarks in regards to bowel preparation rates, cecal intubation rates, withdrawal times, and ADRs, both pre and post intervention. Of note, our adenoma detection rate increased from 28 to 34% after education was provided. While there's no recommended benchmark for the percentage of withdrawal time greater than 6 minutes, we were consistently performing greater than 90% in both pre and post intervention. We then looked at our overall endoscopy unit performance with regards to ADR by gender. The rates for males improved from 32 to 41% pre and post intervention, while the rates for females improved from 22 to 26%. All pre and post intervention ADRs for both males and females were above national benchmarks as a combined unit. When performing subset analysis on just the gastroenterologist performance, the rates for males improved from 38% to 42% pre and post intervention, while females remained stable around 29%. All pre and post interventions for adenoma detection rates for the gastroenterologist was above national benchmarks for males and females. So subset analysis on surgeon performance demonstrated an improvement in male ADR from 24 to 36%, which put them above national benchmarks. For the female patients, the rates were 17 and 15%, both below the national benchmarks. It should be noted that during the post-intervention review, Of the 3 surgeons at our institution who routinely perform screening colonoscopies, 1 had deployed and another retired, thus leaving us only 1 surgeon to perform screening colonoscopies. Due to this change in manning, the single surgeon was only performing 21% of the screening colonoscopies, whereas before the surgeons were performing roughly half of all screening colonoscopies. In conclusion, a quality improvement program can be implemented at a DoD tertiary medical center. However, it requires a system for capturing and reporting data, in addition to a dedicated program that focuses on improving endoscopic techniques. While initial educational interventions have resulted in global increases in ADR at our institution, we still have room to grow. Regardless of starting point, every endoscopist has the potential for improvement. It requires a collaboration and commitment by all in order for this to be a success. Thank you again for your attention, and I'm happy to answer any questions.